So, as a part of the continuation of the previous session, we were discussing the juvenile myoclonic epilepsy. So, a few more questions on the juvenile myoclonic epilepsy, that is, which of the following is effective as monotherapy as a replacement for sodium valproate in a female of childbearing age group for treatment of juvenile myoclonic epilepsy? The options are levetiracetam, lacosamide, phenytoin, carbamazepine. So, the drug of choice for the juvenile myoclonic epilepsy, already I have discussed in the previous session, that is valproic acid. Right, that is valproic acid. Now, in females of childbearing age group, and in females who are about to conceive, and when the individual is in first trimester of pregnancy with juvenile myoclonic epilepsy, valproic acid is not advised. Right, valproic acid is not advised. Okay, so in this group of individuals, valproic acid should not be given because valproic acid, it has teratogenic risk. Right, valproic acid, it has, or it is associated with the teratogenic risk, and that is the reason why valproic acid is not at all given in the childbearing age group females and as well as in the first trimester of pregnancy. Now, in those individuals, right, in whom valproate is contraindicated or not tolerated, the treatment is done with the following drugs. So, the drugs that we need to give is levetiracetam, right, and the other alternative drug is lamotrigine, and the third important drug is the topiramate. Right, so these are the alternative drugs that you need to give if you are unable to give valproic acid in case of juvenile myoclonic epilepsy. So, if the question is asked like safest anti-epileptic drug in pregnancy, right, leave about the juvenile myoclonic epilepsy, in pregnancy for epilepsy, what is the safest anti-epileptic drug? Safest will be levetiracetam, followed by that we have lamotrigine, and next to this levetiracetam and as well as lamotrigine, the other drugs that you can give is topiramate. Whereas anti-epileptic drugs like valproic acid, phenytoin, they are teratogenic, so usually they are avoided. And there are certain anti-epileptic drugs that should be avoided in case of the juvenile myoclonic epilepsy. See, drugs like carbamazepine, which is a drug of choice for focal epilepsy, phenytoin, which is given in both GTCS and focal epilepsy, oxcarbamazepine, particularly given in focal epilepsy, these drugs, they should be avoided in juvenile myoclonic epilepsy. Now the question is why? Because this carbamazepine, phenytoin and as well as oxcarbamazepine aggravate the absence seizures. Right, will aggravate the absence seizures. So that is the reason why these three anti-epileptic drugs, they are avoided. And the other anti-epileptics like gabapentin, pregabalin and tiagabin, even these three anti-epileptic drugs should be avoided because they will aggravate they will aggravate all seizures. That is the reason why your gabapentin, pregabalin and as well as tiagabin should be avoided. So you see this question now. Which of the following drugs is effective as monotherapy as a replacement for sodium valproate in a female of childbearing age group for the treatment of the juvenile myoclonic epilepsy? Levetiracetam, lacosamide, phenytoin, carbamazepine. So the ideal drug that you should consider in this patient should be levetiracetam rather than the sodium valproate, because sodium valproate is teratogenic. What is the teratogenicity? I'll explain you. Now you see another question. A 4-month pregnant lady on treatment with valproate regularly asked for your advice regarding taking the drug during pregnancy. What is the best course of action? Immediately taper off valproate and start lamotrigine. Second option, change to carbamazepine. Third option, continue valproate and monitor the blood levels. Slowly taper the dose of the valproic acid. See, she is a 4-month-old pregnant lady, right? She is a 4-month-old pregnant lady and she is on treatment with the valproic acid. So 4 months, in the sense the organogenesis is finished. Right? Organogenesis in this patient is over because the organogenesis will occur in the first trimester. Right? The organogenesis will occur in the first trimester. So in this patient, the organogenesis is over and she is in 4th month and she is on valproic acid. Always remember, the drug of choice in juvenile myoclonic epilepsy is valproic acid. And if a patient with juvenile myoclonic epilepsy is planning pregnancy, then the patient should switch from valproate to lamotrigine, right? Because valproate is associated with the teratogenicity. But an important point is that patient is in 4th month. That means the organogenesis is over. The damage to the fetus cannot be prevented as the organogenesis is almost complete. So, in established pregnancy, changing to an alternative anti-epileptic drug therapy should not be undertaken. Right? Changing to alternative anti-epileptic drug therapy should not be undertaken. Okay, why? Because changing to the other anti-epileptic drug may precipitate the seizure, right? Will precipitate the seizure. So, changing to the other alternative anti-epileptic drug should never be done. Second point is, overlapping the anti-epileptic drug during the change exposes the fetus to the effect of additional anti-epileptic drug. See, you see here, immediately taper off and start lamotrigine. You should not do overlapping of anti-epileptic drug during the pregnancy, because that overlapping of the drugs will expose the fetus to the effects of the additional anti-epileptic drug. And let me tell you, change to carbamazepine, there is a limited advantage of changing anti-epileptic drug if pregnancy has already been established and she is in 4th month. So, better in this patient, continue the valproate and monitor the blood levels. Right? Don't overlap the drug, don't change the anti-epileptic drug, and don't slowly taper and stop the drug. Now, what is the teratogenicity associated with the valproic acid? So with the valproic acid, the teratogenicity which occurs is the neural tube defects, and that particular neural tube defect, it is in the form of the spina bifida, right? That particular neural tube defect, it is in the form of the spina bifida. Okay, so spina bifida, we have three forms: spina bifida occulta, meningocele, and then myelomeningocele. These are the three forms of the spina bifida. See, in case of spina bifida occulta, there is opened posterior vertebral body, right? So you can see that here. Whereas in meningocele, there is protrusion of the meninges in case of meningocele. Whereas in myelomeningocele, there is protrusion and opened spinal cord as well. So the spinal cord and as well as meninges, both of them, they protrude. That will be your myelomeningocele. So these are the forms of the spina bifida. Now, regarding the teratogenicity about the various groups of drugs, I will discuss that in detail. But before that, let me tell you what are the drug of choice for various types of epilepsy. Majority of the forms of epilepsy, we use the valproic acid, because valproic acid, it has a broad spectrum of action, right? Broad spectrum of anti-epileptic action. So you take in patients with GTCS, atonic seizures, myoclonic seizures and absent seizures, valproic acid is considered as the drug of choice. Whereas you take in case of the febrile seizures, during an episode of the febrile seizures, the drug of choice that you need to consider is intranasal midazolam. Right? Intranasal midazolam, or you can give rectal diazepam. So that is the treatment for febrile seizures during the episode. Whereas what is the anti-epileptic drug which is given for prophylaxis of the febrile seizures? For prophylaxis of febrile seizures, the drug that you have to give is oral diazepam. And in case of absent seizures of age group less than or equal to 4 years, the drug that you need to give is ethosuximide. In case of infantile spasm, the drug of choice is ACTH, right? That is adrenocorticotropic hormone. Whereas in case of infantile spasm in tuberous sclerosis, right? Infantile spasm in tuberous sclerosis, the drug that we need to give is vigabatrin. And in case of status epilepticus, the drug of choice will be lorazepam. Whereas in case of refractory status epilepticus, the drug of choice is midazolam. Right? So these are the drug of choice in various types of the epilepsy. Right? This table is very, very important. You need to know for your exams. Now, what is the treatment that you will give in case of medically refractory epilepsy? In medically refractory epilepsy, first of all, the diet which is advised to the patient is the ketotic diet, and you need to do vagal nerve stimulation. right, vagal nerve stimulation. And third important form of the treatment is deep brain stimulation. Right, and the other form of therapy is surgery. Right, in case of the temporal lobe epilepsy, you need to do lobectomy. Right, temporal lobe lobectomy you have to do. That will give you the best results. So this will be the treatment of medically refractory epilepsy. Now you see one clinical scenario. A 15-year-old boy with epilepsy on treatment with combination of valproate and phenytoin has good control of seizures. Right, has good control of seizures. Levels of both drugs are in therapeutic range. All of the following adverse effects can be attributed to valproate except weight gain of 5 kgs, serum alanine aminotransferase 150 international units per liter, rise in serum ammonia levels by 20 grams per deciliter, lymphadenopathy. So the question is like all of the following adverse effects can be attributed to valproate except, that means which of the following is not the feature of the valproate toxicity. See, valproate is one of the commonly used anti-epileptic drug. So you should be completely aware of the adverse effects associated with the valproic acid. So the mnemonic is valproate. V stands for vomiting and as well as nausea. A is anorexia, right, which is nothing but loss of appetite. Liver toxicity. See, because of this liver toxicity, in these individuals, there will be rise in the ammonia levels. Right, and there will be also increase in AST and as well as ALT. And then these individuals, they also have the pancreatitis. Now secondary to this pancreatitis, there will be increase in the lipase levels. Right, and obesity is another important adverse effects. R stands for retention of the weight. O is edema. A is alopecia where there is loss of hair. T is teratogenicity. So what particular teratogenicity? That is in the form of the spina bifida. It is not just only spina bifida, right? The teratogenicity that can be seen with the valproic acid is, number one will be spina bifida, and the other teratogenic adverse effects include the development of ASD, atrial septal defect. Next, cleft palate. Then there will be also polydactyly, right, so where you have the presence of multiple fingers, and hypospadiasis, right, where there is abnormal urethral opening. So that will be the teratogenicity associated with the valproic acid. And T stands for tremors and E stands for enzyme inhibition. So these are the adverse effects that are associated with the valproic acid. Now these individuals, the teratogenicity whatever is associated with the valproate, we call it as fetal valproate syndrome. Right, we call this as the fetal valproate syndrome. Okay, so this is about the adverse effects which are associated with the valproate. Now if you take the teratogenic drugs, see, apart from anti-epileptic drugs, we have many drugs which are teratogenic. I'll just give you a list, right, even though it is not important in the anti-epileptic drugs, I just want to give you a list here because I'll just tell you a mnemonic. The mnemonic is teratoma, right? It is not teratoma, it is teratoma. T stands for thalidomide, right, where the individual will develop seal-like limbs. E stands for epileptic drugs, right, that is anti-epileptic drugs like valproate and as well as phenytoin. R stands for retinoid supplementation, that is vitamin A. T stands for, see, we have a third element in the table of, in the chemistry we learn the tables. The third element is so we have hydrogen first, helium second, and then lithium. So lithium is also teratogenic, where the individual will develop Epstein's anomaly. And the other one is A. Okay, so A we have missed. Okay, so here A should be there, that stands for ACE inhibitors or angiotensin receptor blockers. So ACE inhibitors or angiotensin receptor blockers, they can cause renal agenesis. And O we have is oral contraceptive pills. W we have is warfarin. And last A we have is alcohol. Right? So these are the teratogenic drugs. And these should be avoided during pregnancy, or these should be avoided in individuals who are about to conceive. Another very commonly used drug is the phenytoin. You need to be very much aware of the adverse effects which are associated with the phenytoin as well. The mnemonic is same. Phenytoin itself is a mnemonic, right? For valproate, I have given you a mnemonic, that is valproate. For phenytoin, if you see, P stands for P450 interactions. H stands for hirsutism, where there is excessive growth in the body hair. E stands for enlarged gums. N stands for nystagmus. Then Y is yellow browning of the skin. Right, yellow browning of the skin. T stands for teratogenicity. O stands for osteomalacia. Then I stands for interference with vitamin B12 metabolism. Right, interference with vitamin B12 metabolism. N stands for neuropathies. Right, so the individual, because of neuropathy, they can have the ataxia. Right, the individual will also have vertigo. So these are the adverse effects which are associated with the phenytoin. So as like what we have like fetal valproate syndrome, we also have what is called fetal hydantoin syndrome. Now, what is this fetal hydantoin syndrome? Fetal hydantoin syndrome includes the appearance of the cleft lip and as well as the cleft palate, congenital heart disease, slowed growth, and the mental deficiency. These are the features of the fetal Hydantoin syndrome, right? So these are the adverse effects. These are seen in adults or children taking this phenytoin for long term. That is hirsutism and as well as the enlargement of the gums. So these are the features of the fetal Hydantoin syndrome. So you see this clinical question like what I have shown you before. Now the question is like, which of the following adverse effect is not associated with the valproate? Weight gain of 5 kg, that is obesity, I have said you it will be there with valproic acid. Serum alanine amino transaminase levels are elevated, 150 international units per liter. So that means liver enzymes, they are elevated. Normal value is like 15 to 40. And this valproate is associated with the hepatotoxicity, so due to which the liver enzymes are elevated. Rise in serum ammonia also will be there because of hepatotoxicity. But lymphadenopathy is not the feature associated with the valproic acid. Lymphadenopathy, it is associated with these two drugs, these two anti-epileptic drugs. One is phenytoin and the other one is the primidone, right? So this is about the adverse effects which are associated with the valproic acid. So after having discussed about juvenile myoclonic epilepsy, focal epilepsy, absence seizures and generalized tonic-clonic seizures, let me discuss about the myoclonic seizures. That is, myoclonic seizure typically seen in subacute sclerosing panencephalitis, cerebellar lesion, pontine lesion, thalamic lesion. Myoclonic seizure typically it is seen in patients with the SSPE. Now, what does this SSPE stands for? SSPE, it is subacute sclerosing panencephalitis. Right, subacute sclerosing panencephalitis. So that is what is your SSPE. Now, this subacute sclerosing panencephalitis, it is a chronic complications of the measles. Right, it is a chronic complication that you will encounter in measles. And this is nearly always a fatal disease. Right, this is nearly always a fatal disease. And this subacute sclerosing panencephalitis, it is believed to be caused by altered measles virus. Right, it is believed to be caused by altered measles virus. And this altered measles virus, it remains intracellularly in the brain for many years. Right, it remains intracellularly within the brain for many years. And this subacute sclerosing panencephalitis, the clinical manifestations that will appear in 4 stages. Stage 1 is that where the individual will have irritability, they'll also have reduced attention, and temper outbursts. Right, so these are the features that you will see in stage 1 of SSPE. And you take stage 2 SSPE, these individuals, they'll have severe myoclonus. Right, these individuals, they'll have severe myoclonus, and they also have they also have involuntary movements and repetitive myoclonic jerks. Right? So these are the features that you will come across in stage 2 of subacute sclerosing panencephalitis. And in stage 3, there is involvement of the basal ganglia. So because of the involvement of the basal ganglia, the individual will have chorioathetosis. Right, which is nothing but the involuntary movement. Chorioathetosis is nothing but where there is involuntary movement within the extremities, that is dancing like movements within the extremities, that is called chorioathetosis. And immobility, they can have dystonia, right, and they'll also have lead pipe rigidity, right, they'll also have lead pipe rigidity. And these individuals, because of the involvement of the basal ganglia, they will also have altered sensorium and the individual will go into a stage of stupor and coma. These are the features that you will have in the involvement of the basal ganglia. Stage 4 is that in case of subacute sclerosing panencephalitis, the altered measles virus will destroy the vital centers of the brain. Right, will destroy the vital centers of the brain like vasomotor center, respiratory centers. They are destroyed in stage 4 of the disease, and due to which the individual will ultimately die. That will be stage 4. So stage 1, the individual will have irritability, reduced attention and temper outbursts. Stage 2, severe myoclonus, involuntary movements and repetitive myoclonic jerks. Stage 3, there is involvement of the basal ganglia, due to which there will be chorioathetosis, immobility, dystonia, lead pipe rigidity, altered sensorium, stupor and coma. And stage 4, where there will be destruction of the vital centers of the brain and finally the individual will die. So these are the features of the subacute sclerosing panencephalitis, right? So myoclonic seizures, they are typically seen in case of SSP. Now in case of the progressive myoclonic epilepsy, what are the inclusion bodies that you will see? Right? Inclusion bodies seen in progressive myoclonic epilepsy: Bushnell bodies, Levi bodies, Hirano bodies, Lafora bodies. So inclusion bodies, the other name of it is, they are also called as elementary bodies. Right, they are also called as elementary bodies. And these inclusion bodies, they are present either in the nucleus or in the cytoplasm. Right, they are present either in the nucleus or cytoplasm. Right, so they are like nuclear or cytoplasmic aggregates of stable substances. Right, so aggregates aggregates of nuclear or cytoplasmic substances, they form the inclusion bodies. And what does these inclusion bodies contain? Inclusion bodies, they usually contain the proteins, right? They usually contain the proteins, and these inclusion bodies, let me tell you, they represent the sites of viral multiplication. Right? They represent the sites of viral multiplication in a bacterium, right? And this elementary body, it consists of which part of the viral material? This elementary body, it consists of viral capsid protein. Right, it consists of the viral capsid protein. That is about the inclusion bodies. So inclusion bodies seen in case of the progressive myoclonic epilepsy. What will be the answer? That will be the Lafora bodies. Right, that will be Lafora bodies. Now you should know, see, this inclusion bodies, it's a very important question. We have various inclusion bodies which we will come across within the nervous system, and that we call it as intraneuronal inclusion bodies. So we have the Pick's bodies in the Pick's disease, then Lewy bodies are seen in case of the Parkinson's disease, then Hirano bodies present in Alzheimer's disease, then Bunina bodies seen in patients with amyotrophic lateral sclerosis, Lafora bodies seen in case of progressive myoclonic epilepsy, Marinesco bodies seen in a normal brain tissue. Right, seen in normal brain tissue. So the inclusion bodies seen in progressive myoclonic epilepsy will be the Lafora bodies. Now, what exactly are these Lafora bodies? Lafora bodies, they are polyglucosan bodies. Right, they are polyglucosan bodies. And where are they present? They are present within the cytoplasm. They are intracytoplasmic, right? Intracytoplasmic inclusion body. And this polyglucosan body, that is Lafora body, it is a rounded periodic acid shift positive body. So it is a PAS positive body, and it is present within the cytoplasm. And what does this contain? What does the core component of the Lafora body? It is intracytoplasmic inclusion body with a dense central basophilic core. Right, with a dense central basophilic core and a rim that takes up a lestine found in larger neurons of the thalamus. Now, in which part of the brain you have this particular Lafora bodies? These Lafora bodies are present within the thalamus. They are present within the dentate nuclei. they are present within the substantia nigra, right, present within the substantia nigra in progressive myoclonic epilepsy. So these are the important points regarding the Lafora bodies. They are nothing but polyglucosan bodies. They are periodic acid shift positive bodies. They are present within the cytoplasm with a dense central basophilic core, and they are present within the parts of the brain like thalamus, dentate nuclei and substantia nigra. That is about the Lafora body or the polyglucosan body. Now, having discussed about the progressive myoclonic epilepsy, so myoclonic jerks or myoclonic epilepsy, one of the clinical scenario where you will come across is SSPE, subacute sclerosing panencephalitis. And you need to know about the epilepsy in pregnancy. So you need to know this important terminology called eclampsia. So eclampsia, what is this? It is the disorder in pregnancy where the pregnant female will develop seizures, and along with that there is the preeclampsia as well. Now, what are the features of preeclampsia? Preeclampsia, it is defined as a condition seen after 20 weeks of gestation. First and foremost, very important point, preeclampsia is a condition seen after 20 weeks of the gestation. And the second important thing is, these individuals with preeclampsia, they will have pregnancy induced hypertension. Right? Pregnancy induced hypertension. And the third important feature is the presence of proteinuria, significant proteinuria. So these three are the components of preeclampsia. First of all, first thing, preeclampsia means it should be there after 20 weeks of gestation. The other two important things is there will be pregnancy induced hypertension and as well as the proteinuria, right? Now, what will be the treatment? See, these patients, you need to give magnesium sulfate. Magnesium sulfate is used to both prevent the seizures in patients with severe preeclampsia and treat the seizures once they develop, right? So magnesium sulfate, it is given to treat the seizures, and not only treat the seizures, this magnesium sulfate will also prevent the development of the seizures. That is what is the treatment for eclampsia. And regarding this supplementation of magnesium sulfate, you need to know some important guidelines. See, this magnesium sulfate should be given once a decision to delivery has been made. So, you want to induce the labor or you want to deliver the baby. That is the point when magnesium sulfate has to be given. So, this should be given once once decision to delivery has been made. And in eclampsia, you need to give an IV bolus first. And this particular IV bolus, the dose that you need to give is 4 grams. And this particular 4 grams should be given over, should be given over 5 to 10 minutes, right? And after giving a bolus dose, this should be followed by an infusion of 1 gram per hour, right? This should be followed by an infusion of this should be followed by an infusion of 1 gram per hour, right? And what is that you need to monitor whenever you are giving this particular magnesium sulfate? You need to monitor the urine output, you need to monitor the reflexes, you need to monitor the respiratory rate, right? And you need to monitor the oxygen saturation. Right, you need to monitor the oxygen saturation. So these all have to be monitored during the supplementation of the magnesium sulfate. And this particular treatment, how long you have to continue? Treatment should continue for 24 hours after the last seizure. Right, treatment has to continue 24 hours after right, 24 hours after the last seizure or 24 hours after the delivery. Right, 24 hours after the delivery. So this is about the guidelines of the supplementation of the magnesium sulfate. And what about the epileptic patient have become pregnant, right? Or an epileptic patient is breastfeeding. What are the precautions that you need to follow? See, the risk of uncontrolled epilepsy during the pregnancy generally outweigh the risk of medications to the fetus. Any of your anti-epileptic drug you give, they are slightly teratogenic. But the risk of uncontrolled epilepsy during the pregnancy generally outweigh the risk of medication to the fetus. So all women thinking about becoming pregnant should be advised to take folic acid 5 milligrams well before pregnancy to minimize the risk of the neural tube defects. Okay, so epileptic patient have become pregnant. What the individual has to do is, all women thinking of about becoming pregnant should be advised to take folic acid 5 milligrams per day should be given. Right, folic acid 5 milligrams per day should be given well before the pregnancy, right? And that is mainly to reduce the risk of neural tube defects. Right, that is to reduce the risk of the neural tube defects. And around 1 to 2% of newborns born to non-epileptic mothers, they have these congenital defects. But the risk of congenital defects increases if the mother takes anti-epileptic medication. So, anti-epileptic drugs, they increase the risk of right, they increase the risk of congenital defects by almost 3 to 4%. Okay, so that is about the pregnancy and the breastfeeding. So you have to give anti-epileptic drugs because the risk of epilepsy or the risk of seizure during the pregnancy is very much high than compared to the risk of medication to the fetus. But you have to mainly aim for monotherapy. One anti-epileptic drug, levetiracetam, right? A very good anti-epileptic drug in pregnancy, right? And there is no indication to monitor the anti-epileptic drug levels. Sodium valproate, as already I have said you, the teratogenicity that is caused by the sodium valproate is the neural tube defects. And carbamazepine, it is least teratogenic right, it is least teratogenic compared to that of all other anti-epileptic drugs. Phenytoin, just now we have discussed, associated with fetal Hydantoin syndrome, right, associated with cleft palate. Whereas lamotrigine, it is associated with the development of very few congenital malformations, right, and this is considered to be a safe anti-epileptic drug during pregnancy. So both the levetiracetam and as well as lamotrigine, these two drugs, they are considered to be safe anti-epileptic drugs during pregnancy, right? And what about breastfeeding? Breastfeeding is generally considered safe for mothers taking anti-epileptic drugs with the possible exceptions of the barbiturates, right, with the possible exceptions of barbiturates. It is advised that pregnant women taking phenytoin, they are given vitamin K in the last month of pregnancy to prevent the clotting disorders in the newborn, right? So this is a very important point that you need to know, right? So a pregnant woman taking phenytoin, she has to be given vitamin K in the last month of pregnancy, that is mainly to prevent the clotting disorders in the newborn. Very important point. Next, having said this, you need to know the next important form of the seizures, that is in the seizures in the newborn. So until now, like what we have discussed is about the anti-epileptic drugs and pregnancy. Now the very important question is the commonest type of seizure in the newborn: clonic, tonic, subtle, myoclonic. So the most common type of seizure in the newborn are the subtle seizures, and these particular subtle seizures, they constitute 50% of all seizures that you will come across in the newborn. Now this particular subtle seizures, what is the most common cause? See, most common cause of the subtle seizures are HIE, right? HIE stands for hypoxic ischemic encephalopathy. Right, hypoxic ischemic encephalopathy, that is the most common cause of the subtle seizure. And what are the other causes? Right, what are the other causes of the subtle seizures? They include hypoglycemia, and hypocalcemia. These are the other causes of the subtle seizures. And why are they called the subtle seizures? They are called subtle seizures because the clinical manifestations are often mild and frequently missed. Right? So the clinical features, they are often mild and they are frequently missed, and that is the reason why they are called subtle seizures. And these subtle seizures are usually mild paroxysmal alteration in motor behavior. right? Paroxysmal alteration in motor behavior or paroxysmal alteration in autonomic functions. Right? Paroxysmal alteration in motor behavior or autonomic function. So, these subtle seizures, they are of various forms. The common examples of the subtle seizures, they are of the following forms: ocular, orofacial lingual movements, limb movements, autonomic phenomenon. So you take the ocular form of the subtle seizures. Ocular form of subtle seizure is, it is the disorder characterized by a tonic horizontal deviation of eyes, right? Characterized by tonic horizontal deviation of eyes, or the individual will have a sustained eye opening with ocular fixation. Right? Sustained eye opening with ocular fixation. That is what is your ocular form of subtle seizures. Then we have oral facial lingual movements. Oral facial lingual movements, that will be in the form of chewing, that will be in the form of tongue thrusting, or in the form of lip smacking, right? Or in the form of lip smacking. So that is what is your oral facial lingual movements. And if you take the limb movements, they are in the form of cycling, in the form of paddling, in the form of the boxing jabs. So these are the limb movements that you will observe in case of the subtle seizures. Autonomic phenomenon in case of subtle seizures can be in the form of either tachycardia or bradycardia, right? So these are the common examples of the subtle seizures. So subtle seizures, they are the most common type of seizures in newborn, and they constitute 50% of all seizures. And most common cause of subtle seizure is hypoxic ischemic encephalopathy. And other causes of subtle seizure are hypoglycemia and hypocalcemia. And they are called subtle seizures because the clinical manifestations are often mild and frequently missed. And these subtle seizures are usually mild paroxysmal alteration in motor behavior or autonomic function of the individual. And the common examples of the subtle seizures are ocular form of subtle seizures, that is tonic horizontal deviation of eyes or sustained eye opening with ocular fixation. Oral facial lingual movements, that is chewing, tongue thrusting or lip smacking. Limb movements are in the form of cycling, paddling or boxing jabs. Autonomic phenomenon, that is in the form of tachycardia or the bradycardia. Now, what is the anti-epileptic drug of choice for neonate? Anti-epileptic drug of choice for the neonate, it is phenobarbital, right? That will be phenobarbital. So that will be your subtle seizures, right? Or the anti-epileptic drug that you need to give in case of the newborn. Now, after having discussed about the subtle seizures or the seizures in newborn, you need to know an important form of epilepsy, that is the status epilepticus. So, the next important form of epilepsy that you need to know is about the status epilepticus. So, the question is like, all of the following drugs are used for managing status epilepticus except phenytoin, diazepam, thiopentone sodium, carbamazepine. What exactly is the definition of status epilepticus? I have taught you in the beginning of the session itself. But this status epilepticus, what did I tell you, right? It is the one where the individual will have the continuous seizures or repetitive seizures with impaired consciousness in the interictal period. So between the episodes of seizures, you don't have the regaining of the consciousness of the individual. And this status epilepticus, it has the numerous subtypes, right? And what are the subtypes of, right? What are the subtypes of the status epilepticus? The subtypes of status epilepticus include, number one, generalized convulsive status epilepticus. Right, generalized convulsive status epilepticus. Then followed by that, we have non-convulsive status epilepticus. Right, generalized convulsive status epilepticus and non-convulsive status epilepticus. So, generalized convulsive status epilepticus is that where the individual will have persistent generalized electrographic seizures and the individual will have persistent tonic-clonic movement. Okay, so the individual will have persistent tonic-clonic movement. That is what is your generalized convulsive status epilepticus. Then we have non-convulsive status epilepticus. So non-convulsive status epilepticus is that where the individual will have a persistent absent seizures. Right, persistent absent seizures. So what did I tell you in case of the absent seizures? In case of absent seizures, you don't have any abnormal involuntary movements, right? You don't have any abnormal involuntary movements. That is what is your non-convulsive status epilepticus, where the individual will have persistent absent seizures, right? Or the individual will have partially impaired consciousness and minimal motor abnormalities. That will be the two important subtypes of status epilepticus. One is generalized convulsive status epilepticus and the second one is non-convulsive status epilepticus. And what will be the duration of this particular persistence? The duration will be nearly for around 15 to 30 minutes. Right, this will be for nearly around 15 to 30 minutes, right? And or one episode which will be there for nearly around 5 minutes. Then how do you treat these patients? What will be the drug of choice? See, the drug of choice in case of the status epilepticus will be lorazepam, right? Particularly in case of the convulsive type of status epilepticus, drug of choice will be lorazepam. And the dosage of lorazepam is 0.1 to 0.15 milligrams per kg intravenously over 1 to 2 minutes. And you have to repeat if there is no response after 5 minutes. So you can just give 2 doses of lorazepam. And if the patient is not responding in spite of 2 doses of lorazepam, then the alternative drug like what we have is fosphenytoin. Fosphenytoin, the first dose will be like 20 milligrams per kg right? You have to give through the intravenous route, and you have to give at a rate of 150 milligrams per minute. And if with the first dose of 20 milligrams, if the patient does not respond, then you need to give 7 to 10 milligrams, that is the second dose of the fosphenytoin. And for suppose if the patient is on valproate, you need to consider valproate 25 milligrams per kg intravenously in patients normally taking valproate and who may be subtherapeutic, right? See, what is the most common cause for status epilepticus? That is inadequate anti-epileptic dose or abstinence, or that is stoppage of the anti-epileptic drug intake. These are the common causes for status epilepticus. So you need to consider the valproate if the patient is already on valproate. So in spite of 2 doses of the phenytoin, if the patient is not responding and patient is not on valproate, now the next alternative drug that you need to consider is valproate. And valproate you have to give at a dosage of 25 milligrams per kg through the intravenous route. And even with the valproate, the patient is not responding, then you need to consider giving phenobarbital. So phenobarbital you have to give at a dosage of 20 milligrams per kg intravenously at a dose of at a rate of 60 milligrams per minute, right? At a rate of 60 milligrams per minute. And with 1 dose of phenobarbital, if the patient does not respond, then you need to give 10 milligrams per kg of phenobarbital should be given. So 2 doses of phenobarbital is being given. And in spite of that, if the patient does not respond, then you need to consider giving propofol, right? You need to consider giving propofol. Okay, so that is about the treatment. You can give either propofol or midazolam or the pentobarbital. This is the flowchart of the treatment of status epilepticus. So drug of choice will be lorazepam, right? And not responding with 2 doses, give phenytoin. Not responding with 2 doses of phenytoin or fosphenytoin, give valproic acid. Not responding to the valproic acid, then give phenobarbital. Not responding to 2 doses of phenobarbital, then you need to give this particular propofol or midazolam or pentobarbital should be given. So this will be the treatment strategy in case of the status epilepticus. Now followed by that, let me discuss. So you see this question now. All of the following drugs are used for managing status epilepticus except phenytoin, diazepam, thiopentone sodium, carbamazepine. So carbamazepine will be of no use in the treatment of the status epilepticus. Then coming on to the rare epilepsy syndromes. The rare epilepsy syndromes like what we have is MTLE, that is mesial temporal lobe epilepsy. See, this mesial temporal lobe epilepsy, it is the most common syndrome associated with focal dyscognitive features, right? Associated with focal dyscognitive features, okay? And this particular mesial temporal lobe epilepsy, it is an example of an epilepsy syndrome with distinctive clinical, electroencephalographic and pathological features, right? So it's a most common syndrome associated with focal dyscognitive features, and it's an example of an epilepsy syndrome with distinctive clinical, electroencephalographic and pathological features. And these patients, they have the past history of the febrile seizures in childhood. Right, they have the past history of febrile seizures in the childhood, right? And not only past history of febrile seizures in the childhood, these individuals, they also have right? They also have family history of epilepsy as well. And subsequently, these patients presents with focal seizures with complex automatisms, right? So basically, it is a type of focal epilepsy, right? Basically, it is a type of focal epilepsy. And along with the focal seizures or focal epilepsy, these individuals, they also have complex automatisms. And I said you, they have distinctive electroencephalographic features. The EEG, it shows unilateral or bilateral anterior temporal spikes. Right, unilateral or bilateral anterior temporal spikes that you will see on the EEG. And these patients with mesial temporal lobe epilepsy, when you do an MRI, right, when you do an MRI, the MRI will show you the characteristic hippocampal sclerosis, right, hippocampal sclerosis. And recognition of this particular mesial temporal lobe epilepsy is especially important because it tends to be refractory to treatment with anticonvulsants, right? So these patients with mesial temporal lobe epilepsy, right, that is mesial temporal lobe epilepsy syndrome. So these patients, they are refractory to anticonvulsants. So recognition of this mesial temporal lobe epilepsy is very, very important. So then how do you treat these patients? They respond extremely well to the surgical intervention. Right? They respond extremely well to surgical intervention. So that is about your mesial temporal lobe epilepsy syndrome. Now, followed by that, the another important form of epilepsy that you need to know in infants, that is infantile spasm, which is also called the West syndrome. So these patients with the infantile spasms, they have brief spasms. Right? They have brief spasms beginning in the first few months of life. Right? Beginning in the first few months of life. That is, it begins around 4 to 6 months of life. And this infantile spasm, it is commonly seen in males rather than females. And what will be the involuntary movement that you will have in these patients with the infantile spasms? So these individuals, they'll have flexion of the head, trunk, limbs, and there will be extension of the arms. Right, the flexion of head, trunk, and limbs, and there will be extension of the arms. Right, there will be extension of the arms, and that we call it as the salam attack. Right, that we call it as the salam attack. And this particular salam attacks, that is infantile spasms, they last for 1 to 2 seconds. Right? They last for 1 to 2 seconds. And if you take the frequency, will be up to 50 times. And these individuals, they'll have progressively mental handicap. So, mental retardation will be there. And EEG is the one which is characteristic, and it will help you in diagnosis of this infantile spasms. EEG shows hips arrhythmias. Right? EEG shows hips arrhythmias. So, where you will have interictal, sharp and slow waves with high amplitude. Right? Interictal, sharp and slow waves with high amplitude. Right? And these individuals with West syndrome, how will be the prognosis? They have they have poor prognosis, and the drug of choice will be ACTH, and if the infantile spasm is associated with tuberous sclerosis, then the drug what we give is vigabatrin. Right, the drug what we give is vigabatrin. Okay, so this is about the treatment of the infantile spasms or the West syndromes. So I'll just show you one example of the salam spasm in a 5-month-old baby. Right, so you can see here the episodes, they start, they'll be only just for few seconds. See, this is the posture of the baby before the seizure. And here you can make out the stretched out arms jerking upwards and the legs are bent. And here you can observe tonic bowing spasm. And finally, relaxation and reactive weeping. So that is what is nothing but your salam spasms or salam attacks. Now, after having discussed about the infantile spasms, the other form of the rare epilepsy seen in children is Lennox-Gastaut syndrome. Lennox-Gastaut syndrome, it is characterized by a triad. Right, it is characterized by a triad where you have multiple types of the epilepsy will be there. And these multiple types of epilepsy, they include generalized tonic-clonic seizures, atonic seizures, and atypical absence seizures. Right, so these are the multiple types of seizures that you will have in Lennox-Gastaut syndrome. That is one form of the triad. And the second form of the triad is that the EEG. EEG, it shows slow spike in wave discharges. Right, slow spike in wave discharges. So when you are using the word slow, the frequency is around 2.5 Hertz, and there will be a variety of other abnormalities as well. So the EEG shows slow spike in wave discharges. Right, the frequency is around 2.5 Hertz, and The third important form of the triad is that these individuals, they have impaired cognitive function. Right? They have impaired cognitive function in most but not all the cases. Right? Impaired cognitive function in most but not all the cases. That this is the triad. Number one, multiple types of the epilepsy. Number two, EEG shows slow spike in wave discharges and a variety of other abnormalities. And third important part of the triad is impaired cognitive function in most but not all the cases. And this Lennox-Gastaut syndrome is associated with the CNS disease or dysfunction from a variety of causes, right? And what would be the cause for this Lennox-Gastaut syndrome? That would be perinatal hypoxia causing the Lennox-Gastaut syndrome. And because of this perinatal hypoxia, there can be ischemia of the brain, which is responsible for this Lennox-Gastaut syndrome. Next, trauma, and as well as the infection. Right, trauma and as well as the infection, and some other acquired lesions. So these are, right, these are the etiologies: perinatal hypoxia or ischemia, trauma, and as well as the infections, right? And let me tell you, the multifactorial nature of this syndrome suggests that it is a non-specific response of the brain to diffuse neuronal injury. So secondary to this etiologies, there will be diffuse neural injury, and this particular diffuse neural injury is what is responsible for multifactorial nature of this syndrome, right? Next, so this is a triad in Lennox-Gastaut syndrome, and you take the another form of a rare epilepsy, that is Unverich-Lundberg syndrome or disease. So it is a disorder, it is a neurodegenerative disorder right? It is a neurodegenerative disorder characterized by onset from the age of 6 to 15 years. Okay, so the age of onset will be around 6 to 15 years. And in this Unverich-Lundberg disease, the individual will have stimulus sensitive myoclonus and tonic-clonic epileptic seizures, right? So there will be stimulus sensitive myoclonic jerks and tonic-clonic epileptic seizures. Right, so this is about the Unverich-Lundberg disease, right? Now these are the forms of the rare forms of epilepsy, and in case of the Lennox-Gastaut syndrome, like what will be the treatment? You have, see, these individuals, they are refractory to medical management because there is diffuse neural injury, right? There is diffuse neural injury. So the diet that you have to provide is the ketogenic diet. So this ketogenic diet may help in the treatment of the Lennox-Gastaut syndrome. Now, one of the very important differential diagnosis of the seizures is the syncopal attack. See, you have to be very much thorough to differentiate between the seizures and as well as the syncopal attack. Seizure, right? it can occur either during daytime or nighttime. Whereas syncopal attack, it is the one which occurs only during the daytime. And what will be the position of the patient during an episode of seizure? The individual can have any position. Whereas an individual to have an syncopal attack, the individual should have an upright posture but not recumbent posture. Onset of this particular seizure, it is sudden in onset, right? It is paroxysmal hypersynchronous neuronal discharge, whereas syncopal attack, gradual in onset. And you take the aura, right? That is the premonitory symptoms. The aura, it is possible in case of the seizures, whereas in case of the syncopal attack, the individual will have the dizziness, right, or blurring sensation, or the individual will have lightheadedness. And what will be the color of the lips? The color of the lips in case of an attack of a seizure, it is either normal or cyanotic, right? Either normal or cyanotic. Whereas syncopal attack, the lips appear pale. And what about the autonomic features? The autonomic features in case of the seizures, they are uncommon. Whereas in case of a syncopal attack, the autonomic features are very common. And these autonomic features are in the form of diaphoresis. And what will be the duration of tonic-clonic movement in case of a seizure attack? The tonic-clonic movement will be there for nearly around 30 to 60 seconds in case of seizures. Whereas in case of the syncopal attack, the duration is less than 15 seconds. And what about incontinence? Incontinence is very common in case of the seizures, and incontinence rarely it is being present in case of the syncopal attack. And what about the postictal state? See, in a case of a postictal state, the individual will be in a state of confusion in case of the seizures. Right, postictal confusion. And even in the postictal phase, there can be development of the seizures as well. Generalized tonic-clonic or focal seizure can be there. But this postictal abnormality, it is rare in case of the syncopal attack. And what about motor activity? Motor activity, it is very common in case of, the seizure. That means involuntary motor abnormality will be there in case of seizure. Whereas in case of a syncopal attack, you have, right, you have an occasional motor activity, right? Occasional brief jerk, right, can be there in case of the syncopal attack. And what about the injury? The injury in case of the seizure, it is in the form of the tongue biting, right? So tongue bite will be there, may or may not be there. It is not mandatory, but most of the times it will be there in case of GTCS. And in case of a syncopal attack, the tongue bite is rare. unless if the individual falls over the face and injures the tongue. Otherwise, tongue bite is rare. And what about automatisms? Automatisms, let me tell you, they are very common in case of seizures. Whereas in syncopal attack, you don't have any automatisms. And what about EEG? EEG in case of the seizure, it is either normal or abnormal. Right? It is either normal or abnormal. Whereas EEG in case of the syncopal attack, it will be normal. Right? In syncopal attack, it will be normal. And what will be the duration of unconsciousness? The duration of unconsciousness in case of seizure, it will be there for minutes. Whereas the duration of the syncopal attack will be there for seconds. Right? Duration of unconsciousness in case of syncopal attack will be there for seconds, but whereas it will be for minutes in case of seizures. Right? So this is about the differences between the seizures and as well as the syncopal attack. So syncopal attack, it is one of the very important clinical scenario that has to be differentiated from seizures. And I'll just show you a clinical scenario. A 17-year-old girl is brought into the accident and emergency department with generalized tonic-clonic seizure. Her mother had found her fitting in her bedroom about 20 minutes ago. Right? Seizures episodes are there for about 20 minutes ago. The ambulance crew handover state that her saturations are 96% on 15 liters of oxygen, and they have given her 2 doses of rectal diazepam, but she had not stopped seizuring. What is the most appropriate management? Lorazepam, phenobarbital, intubation, call to the intensive care unit, phenytoin loading. See, this particular patient has already been given 2 doses of the benzodiazepines. Rectal diazepam has already been given now. Again, don't give lorazepam. See, actually what is this clinical scenario? It is a clinical scenario of status epilepticus. So most of you may go on to tick the lorazepam, but lorazepam is not the answer here, because already 2 doses of rectal diazepam has been given while bringing the patient to the emergency department. So now patient has no response. Then what is the next drug in the flow chart I have shown you? That is, you need to give the phenytoin, right? So 2 doses of lorazepam. If the patient does not respond, then you need to give phenytoin or fosphenytoin should be given. So this is about one of the clinical scenario related to status epilepticus. So in this topic, I have just given you a brief introduction of like what is seizure, what is epilepsy, and then what is convulsion. Then followed by that, we have discussed the classification of the seizures, that is psychogenic and neurogenic seizures. Neurogenic seizures, again 2 types, generalized tonic-clonic seizure and as well as the focal epilepsy. Generalized tonic-clonic seizures, again we have the following types, right? That is tonic, clonic, tonic-clonic, atonic, absent seizures, and then the myoclonic epilepsy. And you take the next focal epilepsy, that is simple and as well as complex partial epilepsy. Right, so we have discussed in detail about the various types of epilepsies and the respective treatment, and you need to know the adverse effects and what is that you need to monitor whenever you are giving an anti-epileptic drugs is also very important. So with this, I'll wind up this very important session on epilepsy. Thank you very much.